Welcome to the Patient-Centered Primary Care Collaborative webinar this afternoon. We're focused on the 2017 evidence report, the impact of primary care practice transformation on cost, quality, and utilization. This is Ann Greiner, the President and CEO of the PCPCC, and I'm going to start by just giving a very brief overview of our organization and why we issue this evidence report on an annual basis. For those of you who are not familiar with the PCPCC, we are a nonprofit, multi-stakeholder organization that's 10 years old, and we have focused on making primary care more robust and patient-centered. For the last 10 years, we've really forged a consensus around the patient-centered medical home model and worked across stakeholder groups to get that model widely adopted at both the federal and state levels and also in the private sector. This sixth report on the evidence related to the patient-centered medical home and advanced primary care has really helped to establish the organization as an important source of information about primary care transformation and its effects on patients and the broader healthcare system. This year's report has evolved to include not only the patient-centered medical home, but other models of advanced primary care. And that we've made that change because we do see so many different ways that primary care services are being delivered in the market. And those are captured in the report and also in a document that we will be issuing this October that is the shared principles for advanced primary care. If you have not seen that document, I encourage you to sign on to our website and take a look at it. We are asking people to support those shared principles, and the signatories to that document will be recognized at our annual fall conference, which is on October 11th and 12th here in Washington, D.C. The conference will be focused on innovations in primary care and how these shared principles are being put into practice. So we'd love for you to sign on to those shared principles and to join us at our conference. And if you look at this slide, you'll see that there are links to both the shared principles and also to the conference. One last item to bring to your attention, and you can see in the control panel that the evidence report is there and the slides from today's webinar is a letter from NCQA, and just want to bring that to your attention. They've done an analysis and they've made a case in a letter that is going to CMS, that is a comment letter on the macro draft rule that patient-centered medical homes should receive ACI credit for being a patient-centered medical home, given all the HIT-related standards that practices need to reach to be certified as patient-centered medical homes. So take a look at that letter. You may want to adopt those comments into your own comment letters. And then finally, let me just, before I introduce our speakers, a couple of housekeeping items. There's hundreds and hundreds of people on the call today, so instead of raising your hand and us calling on you, we'll ask you to chat your questions into the chat box. Write your questions into the chat box, and you can do that throughout today's presentation, and then we'll have some time for questions at the end. Also, this recording and the slides we will post on our website within 24 hours. So without further ado, let me introduce our speakers, and we thank them very much for joining us today. We're thrilled to have three eminent experts in the field. First is Dr. Yalda Jabbarpour, and she is a family physician who practices and is also an assistant professor in the Department of Family Medicine at Georgetown, and she is affiliated with the Graham Center. Yalda is the principal author on the report, and we look forward to her remarks. After her presentation, I will offer some policy perspective on the remarks, and implications for federal policy is really what my focus will be. And then we'll ask David Ehrenberger and Brad Roberts to both react to the results in the evidence report. David Ehrenberger is CMO at Health Teamworks, and that his focus there is on practice network transformation solutions. He was most recently for 13 years the Chief Medical Officer and CEO of an independent, high-performing, clinically integrated network in Colorado, and before that, CMO of a community hospital in North Metro Denver. Thanks so much, David, for joining us today. Brad Roberts is currently Strategic Planning Managing Director, Accountable Care Solutions at Aetna, and he spends much of his time tracking value-based payment, looking at how his company relates to value-based models around the whole healthcare industry, and leads Aetna's efforts to hone their own work on value-based contracting. We're very pleased to have both Brad, David, and Yalda with us today. And Yalda, let me turn the baton to you. Oh, actually, before I do, one last thing to let the participants know about. We here at the PCPCC have also, for the last 2 years, been spearheading work with CMMI on transforming clinical practice. This is a CMMI grant that engages patients and families in transforming practices. So we see patient and family engagement as a really important lever in transforming practices. And for you all to get more information about that, please visit our website, and the link is right there. So without further ado, Yalda, we look forward to your presentation.
Thanks, Anne. Hi, everyone. My name is Yalda Jabbarpour, and as Anne mentioned, I'm a practicing family physician in the Department of Family Medicine at Georgetown University School of Medicine, and also a continued collaborator with the Robert Graham Center. And I'm going to give you just a brief overview of our report on the impact of primary care practice transformation on utilization, cost, and quality. So just a couple words about the Graham Center before I dive into details of the report. For those of you who don't know, we are a division of the American Academy of Family Physicians with complete editorial independence. Our staff includes 3 physician researchers, geographers, economists, social scientists. We are a small but pretty prolific team in terms of research. The core team is helped by 2 health policy fellows and about 9 to 11 visiting scholars who are med students, residents, practicing physicians, who all come and spend a month at the center to continue their own research. So we were asked by the PCPCC and Milbank Memorial Fund to conduct a literature review of the evidence published in 2016 regarding the patient-centered medical home. And it wasn't just us at the Graham Center who contributed to this report. So as you can see, this is the list of people involved, and we were a very diverse team in terms of both point of view, and we had diverse stakeholder groups as well. I know there are a lot of people on this call, and many of you out there probably already know a great deal about the PCMH model, but if you'll just indulge me for a moment, I did want to do a brief review for those who may not be as familiar who are on the line. So what is PCMH? Well, in 2007, the major primary care physician associations developed and endorsed the joint principles of the patient-centered medical home. This model of primary care delivery has since evolved, but there are many core attributes that have remained a part of the patient-centered medical home. Number one, obviously, it's patient-centered. So when patients come to my patient-centered medical home, they, their families, their caregivers, and I share in making decisions about their care. It's comprehensive. So in my PCMH, I'm not only taking care of your sprained ankle, but I'm also doing your pap smear and yearly cancer screening, and I'm treating your chronic conditions like diabetes or depression. It's coordinated. So your care is organized across all elements of my broader healthcare system, including the specialist, hospitals, home health care, community services, and support. We're accessible. Many patient-centered medical homes have access to care on nights and weekends, 24/7 electronic or telephone access via patient portals or on-call physicians or nurses, and strong communication through health IT innovation. And finally, we're committed to quality and safety. So we're doing continuous quality improvement projects to make sure that that's happening. So our task was to review the literature published about the patient-centered medical home and advanced primary care in 2016, with a focus on cost, quality, and utilization as outcomes. There were a couple differences this year. One, a new set of authors that I introduced, but also we broadened the scope of research. We didn't only pull and analyze articles that explicitly mentioned that they were PCMH, but also those that had PCMH-like qualities and attributes. We also had a very rigorous search criteria this year. We actually enlisted the help of 2 library scientists, one at Georgetown University and one with the American Academy of Family Physicians, to help us develop appropriate search terms and look through appropriate databases. I'll show you in a second how many articles we found, but we ended up with 45 peer-reviewed literature articles and a few articles that we classified as gray literature. So gray literature were those articles that weren't necessarily published yet in peer-reviewed journals, but that still had a very rigorous methods section. So I'm not going to go into this slide in detail. We do that in the report, but I just wanted to show you this to show you that we had this rigorous search, and we started with over 1,000 articles, which were then reviewed by multiple independent reviewers looking for our search outcomes and our inclusion and exclusion criteria, and ended up with 45 peer-reviewed articles that we then went over in detail. And what we found were that our articles tended to fit into 3 broad categories. So first, we had PCMH implementation studies, and these were those studies that looked at systems that had transformed and looked at their results before and after PCMH, or PCMH versus traditional care. Then we had this set of studies that we called features of PCMH care delivery studies in the report. And these were either non-PCMH models, or it was not mentioned if they were a PCMH, but they had PCMH-like features. So those core attributes I talked about in the beginning. And then finally, there were PCMH enhancement studies. So these were studies where the system had already been transformed into a PCMH, but tried to tweak their PCMH in one way or another to see if it could affect their outcomes. Most of these studies actually included adding a team member to the PCMH to see what that would do. And here's what we found in general. I'll go into each of these in a moment, but here we see that green stands for articles with positive results, yellow stands for those with mixed results, and red for those with negative results. Just a word about mixed findings. So when I talk about mixed findings, we talk about things that fell into 2 categories. Those that had some positive and some negative findings within the same article. For example, some articles looked at their general population and then looked at subgroups. And when they looked at subgroups, they found that there was an impact, but over the general population, there was not a statistically significant impact. Or those articles that reported a trend towards positive or negative findings, but without statistical significance. I'll go into each of these categories in detail in a moment, but the visual takeaway here is that an overwhelming preponderance of these articles either showed positive or mixed results for the patient-centered medical home. So let's look at each individually. If we look at cost, and we divide into PCMH implementation studies, feature of PCMH care delivery studies, and PCMH enhancement studies, we see that in general, there were overall positive results. These results were more impressive for those PCMHs that had been around longer, generally longer than 4 or 5 years, or for those practices that had patients with multimorbidity. In terms of the care delivery study, we did find negative results, but take this with a grain of salt because there was only one study and it was limited to the patients with breast cancer, which tend to be higher cost for the system in general. If we look at quality, we see that in general, the results were mixed. There might be a few reasons for this. Most studies looked at a range of quality measures, anywhere from 4 to 20 measures in one study. So you can imagine that some measures may have improved, whereas others had no change. It was almost impossible to get all your measures to have some statistically significant positive change. Also, the sample sizes may have not been big enough to make any kind of statistically significant change at all. Generally, these measures were looking at subgroups, so diabetics or hypertensives, which obviously would reduce the sample size. I also think it's hard to draw many quality conclusions from these studies because it's unclear if the measures studied actually even made a difference in patient-oriented outcomes. But interestingly, what we did find were that the 3 studies that looked at patient satisfaction as a quality measure actually all showed positive improvements. And then we looked at utilization, and our studies generally looked at 3 parts of utilization. One was primary care physician use, second, emergency department use, and third, inpatient use. And we considered it positive if primary care physician use went up, emergency department use went down, and inpatient stays went down. And when we looked throughout the articles, we generally found that there was an increase in PCP visits and a decrease in ED visits, but there were generally no differences in terms of inpatient stays. And then we turned to the gray literature. And for the gray literature, we looked at 2 large reports and then a few state industry reports within the larger initiative. So the first initiative we looked at was the Comprehensive Primary Care Initiative. This is a 4-year multi-payer initiative that started in 2012. It included 7 U.S. regions and essentially offered population-based care management fees and shared savings to support the core primary care functions. And those functions were, number 1, risk stratified care management, 2, access and continuity, 3, planned care for chronic conditions and preventive care, 4, patient and caregiver engagement, and 5, coordination of care across the medical neighborhood. So those core attributes we talked about in the beginning of the patient-centered medical home. And then there was the multi-payer advanced primary care practice year 3 report. This report didn't fit our study exactly in that it was more of a thematic analysis instead of looking at cost, quality, and utilization, like cost, quality, or utilization like our other studies had. But the multi-payer advanced primary care practice was a 3-year multi-payer initiative that started in 2011. It began with 8 states, and 5 of the 8 states actually continued through 2016. And here they offered a monthly care management fee for beneficiaries in advanced primary care practices, once again to provide those core attributes of the patient-centered medical home. And these are the CPCI results. These are year 3 results. Only the results with 3 stars by them are actually statistically significant. So in terms of cost, year 1, we saw a decrease, but by year 3, this decrease was actually dampened. In terms of utilization, there was a decrease in ED and hospitalizations, but only statistically significantly so in year 3 for emergency department visits. And of all the quality measures they looked at, which were upwards of 50, there was only statistically significant improvement in urine protein testing in diabetics. But this went the opposite direction by year 3. So although these results may not be as impressive as hoped for, when you talked to medical directors and administrators of CPC clinics, which we also did, they really felt that they were making positive changes for their populations in an anecdotal sense. So perhaps, as we saw in our peer-reviewed literature, 3 years just isn't enough time for a demonstration to mature to the point that you would see amazing results. Also, the results were very dependent on geographic regions, perhaps because of either more rigorous measurement standards or market-specific conditions. But I do think it's important to note that CMS also thinks that there were important lessons to be drawn from this multi-payer demonstration because they are expanding CPCI into 14 regions as of January 2017. The hope is that this new initiative, CPC Plus, will integrate many lessons learned from CPC, including insights on practice readiness, the progression of care delivery redesign, actionable performance-based incentives, and necessary health information technology. And if you look at state-specific results for CPCI states, they were actually more positive for certain states than the general program. So 2 states that published state-specific reports this year were Colorado and Oregon. And both Colorado and Oregon showed improvements in terms of cost and utilization for their states. Now, I do have to mention that these states did not only have CPCI as a program in their states, but other grants and other programs as well. And then when we look at the MAPCP results, like I said, the results we had at the time of publication were thematic in nature. And what they found was that care management had the most significant impact on utilization and expenditures. And people also felt that reaching out directly to recently hospitalized patients was important, as well as risk stratifying those patients and allocating resources to those that were most in need. And once again, when we looked at an MAPCP state, in this case, Minnesota, we did find that there was improvements in cost and utilization. And they actually also looked at quality and found improvements in quality of care, especially for their asthmatic patients. So in conclusion, our analysis showed positive overall results in terms of cost, quality, and utilization, but not always uniformly so. And there are some reasons for this. We see that patients with greater comorbidity and systems with these patients may actually show the greater early strides. Also, transformed and transforming practices just need time to mature before significant improvements can be achieved. Studies on practices that had transformed for greater than 4 years, especially in our peer-reviewed literature, did much better. And in fact, if we look at Michigan, which we do focus on as an example in our report, which is the largest and longest running PCMH demonstration, we see many positive results in terms of cost, quality, and utilization. Also, when you've seen one PCMH, you've seen one. So we can't apply a one-size-fits-all approach to the implementation and evaluation of practice transformation. Applying the same metrics when measuring an entire system may not be entirely fair because clinics start off at different places. And finally, there is this concept of spillover effect of transformed practices onto those that have yet to transform, which may be dampening the results for the PCMH. In fact, the PCMH is so widespread that it has become hard to study it in isolation or to have any kind of control group. It's estimated that 45% of all family physicians work in a PCMH, and anecdotally I've taught medical students and residents in 2 different medical schools across the country from each other, and this is the model of care delivery we teach and we use. So I think this is a model that is evolving, but definitely here to stay, and we should continue to support implementation and research on this model as we move forward. Thank you. Allison, I'll hand it back to you.
Well, thank you so much, Yalda, for your presentation. Really appreciate that. And we will have an opportunity for questions after our reactors. But first, let me just make a couple of brief remarks with respect to policy implications. I think you heard from Yalda that transformation is not an overnight prospect. And for those of you who are working with practices to transform or are yourself in those practices, you know that. And this can often be something that policymakers are looking for, that silver bullet. But, you know, I think one of the major messages here of the report is we need to continue to persist with these models, and then we will see results. I think not always uniformly, but we still need to continue to work and evolve these models to achieve what we know can be achieved. Staying with the status quo of fee-for-service medicine or models that do not integrate and coordinate care, we know is not the pathway to reducing costs and improving quality. And so this notion of continued innovation is important. And so that really leads me to my next point, that CMMI has proven itself as an important lever to drive innovation. We know that Medicare, you know, really can influence and shape healthcare markets, and they, over the last number of years, have demonstrated that they can incorporate what they learn from putting these models into place and evolve the models. I think Yalda alluded to that with the results that she showed from the CMMI projects. And also, they have demonstrated that they could partner with the private sector. So these are both new things that CMS is doing, and I think we want to encourage them to continue to support and facilitate innovation and to partner with the private sector. If the public sector goes in one direction and the private sector goes in another, we will not make gains. So we really want to continue to pursue that alignment between what the public and the private sector are doing. Third point is that the public sector as a payer can really lead in providing high-performing primary care as a key low-cost benefit, whether it's through Medicare or Medicaid, through the exchanges, and the like, through OPM and its provision of care to federal employees. It's really important for the federal government to send the signal that that they provide robust primary care, and you know, to pay for that and to support it. And finally, we are all, I think, those of you who are focused on physician payment, working away on your comments on the MACRA rule. I think we want to make sure that the advanced alternative payment models that CMS does incorporate into physician payment for those that are providing care to Medicare beneficiaries continues to support comprehensive care. Primary care is a bedrock, and support for patient-centered medical homes within those models. So let me stop there and ask if Dave Ehrenberg would first provide some remarks. And again, Dave is Chief Medical Officer at Health Teamworks. Let me turn the baton to you, Dave.
Thank you very much, Anne, and thank you, Yalda, for your excellent summary of this very exciting report, now 10 years into this evolution and revolution in primary care. I am a PCMH groupie, I'll confess to that, and it's very clear to me, once again, that the principles of the medical home deliver on the triple aim. So in this report, not buried, but highlighted, are specific examples of where there is improved quality, decreased cost, decreased utilization, improved patient experience in Colorado and Michigan, Oregon, Minnesota, and others. I want to address, first of all, the inconsistencies across these studies. In the tradition of science. This is a tremendous opportunity for us to learn and learn about what works. The model is evolving, and so the Blue Cross Blue Shield of Michigan example details some very important takeaways, such as it takes a community of leadership and collaboration, that physician engagement, they refer to it as sparking physician enthusiasm. These things are essential to where the medical home is going and how how it is effective in terms of impacting the triple aim. There has to be meaningful financial support. Multi-payer participation, I think, is a universal observation as essential to effective implementation. Technical assistance, again, incredibly important. We are embracing technology, and being able to obtain timely and accessible and useful data is critical if the teams that are to deliver advanced primary care are to be effective. And then they also reference embracing team-based approaches that extend the practice. I find this very interesting, extending the practice, so both internally and externally. Who do you have to have on your team? Of course, we've been talking about behavioral health and clinical pharmacology, but also considering that the team doesn't necessarily end at the doors of the medical home, that team, particularly non-healthcare providers in the community, can be critical in delivering on the success of the medical home. And then finally, that the medical home, particularly a walk-the-talk medical home, must mature, and it matures over time. So, having said that, I want 2 more minutes on comments about where I believe that the medical home model, as it stands, particularly with the backdrop of the variety of structures that were studied by PCPCC, where does this model need work in order to deliver on the better care and lower cost? I'm going to pick on 4 areas just because they really stand out. The first one is a editorial, and that is that the patient-centered medical home model is in fact not a quality improvement device. So it actually doesn't surprise me in the least that there is the most inconsistency in the area of delivering on quality via the implementation of the patient-centered medical home. I'm sure it addresses the importance of measurement, and it requires that there are programs addressing improvement, but in fact the model for improvement and the science of quality improvement is just that, is a discrete field that needs to be called out and nurtured. Also, in order for quality and quality improvement, performance improvement really to have an impact, then the people who do the work, the people in the front lines, the teams and the physicians and providers need access to real-time, meaningful, relevant data. The second piece is that the patient-centered medical home is also not a payment model. And I say this really just to underscore something that I hear frequently, which is the opposite, that it somehow or another is a payment model. Of course, it is a vehicle for primary care that is more sophisticated than traditional primary care, and it can be tied to a payment model, but it's not in and of itself a payment model. And the opportunity here is to achieve consistency in the payment models that reward in terms of the value being driven in patient-centered medical home. So consistent measures, management fees, funds flow, valuation. A study a couple of years ago in the Annals of Family Medicine showed convincingly that the incremental cost per physician for a mature medical home was about $105,000 per year per physician. We need to address that head on. The third piece is physician and provider team vitality. This is dear to my heart. I was thrilled to see that this was addressed head-on in the report that was just summarized by Yalda, and referring to it as joy. I personally use the term vitality. The literature currently shows that primary care is under assault, and not by any one factor within healthcare. Burnout rates are remarkably high, greater than 50%. This is a pathology that needs to be addressed, and I think it needs to be addressed in the evolution of the model itself. After all, the physicians and providers and teams, their identities and roles are changing, their accountability is changing. We need to understand the impact on the team, and we need to understand how we can enhance the model to provide purpose and meaningful work in the clinical environment. And then finally, an area that I think needs significant work is how to integrate systems that promote and facilitate understanding and helping with the social determinants of health. We begin to do that when we talk about care management, but we need to push that heavily. I would go so far as to say that the center of patient centering is not within the primary care practice, that the center of patient centering is eccentric to the practice, and that having multidisciplinary teams that are in the community that meet the patient where they're at, particularly the at-risk patients, is vital. And then a corollary of that is to have the data and technology and information in the hands of those who do the work of helping those patients understand who those patients are. I personally have seen in Colorado excellent examples of medical homes, advanced medical homes or advanced primary care that does these things, that is really good and schooled in quality improvement, has taken advantage of every payment model out there to fund their transformation, and that they've invested in care management that is very proactive and out in the community. And the result of that is not only excellent performance in terms of reduced utilization cost, but also relative happiness in the care providers. So that's all I have to say. Thank you.
Oh, sorry. Thanks so much. I really appreciate your comments. And let me turn the mic over to Brad.
Hello, this is Brad Roberts at Aetna. It was great going after David because he had a lot of the same thoughts that I did, and B, it was interesting to hear kind of where they might be different. So I am at Aetna. I've been at Aetna since 2011. I was hired in kind of in a role to focus on what's going on externally. And within the value-based contracting area, when it was obviously pretty young at that time. And my role has stayed, I've very much continued to track the external activity studies, policy, and all those kinds of things, while also being a little more integrated towards model development and strategy. So that's kind of my background. I will say I also spent some time in effectiveness measurement and that kind of thing for the company. These results did not surprise me. The fact that there were some at different stages was not surprising. This is a very thorough report, obviously, as everyone I'm sure has noticed, and that we saw better results with older implementations, and where there was more improvement that could be made, also made a lot of sense. I thought that the case studies showing just how much was required to be successful with this model were important. And to me, they point out, you know, what is the ROI on this? In other words, when we talk about reducing healthcare costs and whether or not these things reduce healthcare costs, does that take into account all the infrastructure that has to be developed? Does it take into account all that extra work? And I think that David's point about social determinants was where my mind immediately went when I started thinking about that. A lot of the work that I do internally and that we're doing as a company is really focused on, you know, I think that's where the major improvement in healthcare can be made. And there was a study recently by, I think it was Commonwealth Fund, that talked about how we compared to the 10 other developed countries. We spent way more money on healthcare. We spent less on social development and such. And if you could put those two things together, we might be kind of similar in terms of how much we spend overall across those two categories, but our health was worse because so many people don't have access to the system was a big takeaway. So, you know, where we can improve the social determinants piece, you know, I've seen a study recently that talks about how alcoholism is a growing issue, alcohol use and abuse and those kinds of things. There are a lot of issues that are not necessarily acute medical care per se that definitely tie into healthcare overall that I think are the purview of either the PCMH or definitely PCMH plays a big role in it. And then another thing I kind of thought was I was thinking of all this is, you know, adoption. So there was a short discussion about the policy piece and CMMI. You know, people probably know that CMMI just lost its leader to Blue Cross in North Carolina. So, you know, as we think about where all that's going, I can definitely tell you that on the private payer side, we're all still very much focused on value-based care, and it's kind of evolved, as I mentioned, to things like social determinants and, you know, how do we kind of holistically take care of our members? Underpinning that, there has to be kind of the policy structure as well, and I think it's where things like MACRA come in. And then my thinking goes to those late adopters, those practices that have not yet adopted PCMH or similar models. What is their experience of all this going to look like once they come in through MACRA? So I took some notes around what David said. Those were kind of my initial thoughts up there. I thought it was very interesting that you said, David, PCMH model is not a quality improvement device. I never really thought about it that way. I think that maybe it's incidental that it should improve quality. I think of PCMH as a care delivery, and I definitely understand what you're saying around payment. So, you know, we doctors are paid differently through the PCMH, but the PCMH proper is really about care delivery itself. Definitely the access to real-time relevant data is a theme, the need for it, how do you improve it? And then I think certainly another theme I see a lot and hear a lot about is the vitality and joy piece. You know, it seems to me like there's a lot of studies have shown differences by age of the physician, for instance. You know, this is definitely, I saw it described or heard it described in a, it might have been CPR, Catalyst for Payment Reform, or the LANE Network. But it was one of the other payment transformation groups that talked about how this is the biggest change management exercise ever attempted in the United States. So, you know, with change management comes an awful lot of grief, and, you know, people will have different abilities to adapt to it and those kinds of things. And to me, it's addressing that and trying to take those best practices from change management and put them into this entire industry is kind of how I would think about that. I think it's all that I have for now. But I mean, to me, the big theme is definitely, you know, the big takeaway to me is definitely around this will pay for itself with better health for the people who are, you know, for United States citizens, basically. And that will probably happen mostly through those social determinants, through not just delivering medical care, but how do you improve their overall health, their health habits, and those kinds of things.
Well, thank you so much to both of you. And now we do actually have some questions. This is Ann Greiner, but I first wanted to just comment on maybe there is a relationship between two of the points that our reactors made, which is this focus on population health, because I think when you talk to primary care physicians and nurses and other providers, they know full well that they're not really constituted in terms of how their practice is organized to address some of these pressing issues, behavioral health or issues with substance abuse, even issues related to food insecurity and the like. And in fact, that can be pretty demoralizing to not be able to address those issues because your practice is not organized to do that, nor are you paid to do that. And so I do see this connection because I've talked to primary care physicians and nurses who are in practices where they have a different payment model and they are beginning to address population health. And in fact, all of a sudden, they are much more joyful in their work because they feel like they really are able to provide that kind of comprehensive care to patients and to meet both their health and their healthcare needs. And so I'm just, as you were reflecting as I was reflecting on your comments, I do see a connection there. You both and Yalda have so much experience here about the patient-centered medical home, and it's really been delightful. Some of the questions that have come in over the transom, Yalda, question for you. In terms of the results from the evidence report, what was most surprising to you as you were doing your research and writing up your results?
Wow, that's a great question. I'm most surprising. I have to say I wasn't surprised by much. Maybe it's just because I'm at the Graham Center and working within PCMHs, and so none of this I wasn't surprised that the results were mixed and not necessarily 100% positive. I would have to say I was kind of surprised that our cost findings were more positive than or more uniformly positive than our cost or quality or even utilization findings. But then when I thought about it more, it made sense, right? Because there's no way to effectively or uniformly measure quality. And as the reactor said, this is not a model for quality improvement. I guess I had wished to see that there were great results in quality with the PCMH. And I think that's more a product of the measures, and maybe we're not measuring the right things, because when we looked at things that I think are important to me as a physician, like patient and provider satisfaction, those actually were improved. So I would say that's it.
Thank you. Question for either Brad or David. Are we really investing enough in practice transformation? I think one of the figures that I think it was David threw out was very large in terms of what it takes to truly transform a practice. And I'm wondering if we are investing enough. The figure that I've seen for proportion of spending on primary care as a function of our entire healthcare spend is between 5 and 7%, or 5 and 7 cents on a dollar. Now, it might be higher in these practices that are transforming, but are we putting enough money into transformation to see the kind of gains we want to achieve? And then, well, David and Brad, you could both answer that question. So whoever, I think I heard David. Go ahead, please.
Yeah, I was just going to say that that's a trick question, because I will say no. And yet, when I quoted the $105,000 per year for physician incremental costs above the running of a basic primary care practice for a full-on PCMH, that amounts to about $4 PMPM for a panel of 2,000 patients. So. But you don't see that kind of payment, even management fees commonly. You may see that level of fee or even higher, but not necessarily for the entire panel of patients who's being cared for. I think one of the tricks is that there are categorical differences in the structure and staffing of PCMH that are essential to its efficacy. One of them is that the ratio of, let's say, MAs or support staff on the clinical side to provider has to be 2 to 1 or 3 to 1 to be able to be effective at the management of populations. Bodenheimer and his team out of UCSF has shown that clearly, and that's been shown elsewhere repeatedly and in my own experience. Secondly, is that we really are underpowered in terms of HIT and data tools that promote effective, high-functioning teams that prepare those teams with current actionable data that identify at-risk patients and that inform those patients as members of the team. Those are two examples that really are not being addressed.
Thank you. Brad, did you want to comment at all on that question?
Yeah, I just asked, I have a couple thoughts. One is, it's quite probable that we're not, but then the question becomes, where does the money come from, right? So is it a public policy choice? Because it's so massive, the thing that you're talking about changing is so massive that it's going to need money at that level. Because clearly, those kinds of numbers you're throwing around, and even I saw a study by MGMA just the last couple of days saying that it's $40,000 per FTE physician, full-time physician, to just to comply with federal regulations. So these kinds of studies show you how daunting the numbers are. And then the other piece is maybe there's some way to reduce the demand, right? So that's the supply of money. Maybe there's some way to reduce the demand for the money in terms of, I know there are efforts going on to align quality measures across the, CMS and the various payers and all that. There are ways that you could reduce the IT footprint, and I think a lot of this is IT we're talking about, IT and probably front office staff and those kinds of things. There are ways to reduce the cost if we kind of were more aligned on things, but right now, of course, and maybe macro will help that or maybe not, but right now we're not really aligned in a lot of ways across payers, across models, et cetera.
Thank you both. Let's see, I think we have time for one more question. This person writes in that they work for a congressperson here in DC, and what should they suggest to their member of Congress that person might do to advance patient-centered medical home and primary care in general? So open it up to anyone who would like to opine on that in our remaining minutes.
Well, I think we just covered some of it, right? More funding maybe for primary care, just at the national level. I think, making sure macro doesn't fall down would be very high up the list right now, particularly around the AAPM side. So there's more, you can see in that survey that people didn't necessarily want to be in MIPS, but that was still where they all said they were going to land. Maybe it's the incentive structure or whatever, but 73% or something like that said that the MIPS measurements they thought were not clinically relevant. So what you're saying is most physicians are not happy with MIPS, but they're going to participate in it anyway. We obviously want everyone to be in these kinds of models, especially people in this group probably, but they're clearly not designed in a way that providers feel like it's making them happy or, it's relevant to them. So how to bridge that gap is maybe a good place to start.
So my takeaway from what you just said, Brad, is policymakers should continue to support this movement to value-based payment, whether it's through sort of the initial steps through MIPS or through advanced APMs, but there's work to do to get to more aligned measures, a streamlined set that are more clinically relevant and really can help to drive improvement. Well, we are at the top of the hour, so I really want to thank the hundreds of folks that have joined us this afternoon for a really great presentation on the PCPCC evidence report and our expert reactors. Again, this presentation and the slides and the recording will all be on our website within the next day, so you can send a link to your colleagues. And again, thank you so much to our presenters, Yalda, David, and Brad. Good afternoon, and we'll sign off now. Bye now.